Hello, everyone. I'm Madeline Milka, President and CEO of APAICS, the Asian Pacific American Institute for Congressional Studies. I am thrilled to welcome you to the third annual APAICS Health Summit. We are honored to have you all here today to discuss the important issues facing our nation's healthcare system and its effects on the Asian American, Native Hawaiian, and Pacific Islander community. This summit brings together experts, policymakers, and stakeholders from across the healthcare landscape to discuss innovative solutions and collaborative strategies to address these challenges. We are thrilled to have a diverse and distinguished group of speakers who will share their insights and expertise on some of the most pressing issues facing our healthcare system today. From expanding access to care, to addressing health disparities, to promoting innovative research and technologies. This summit will provide a platform for us to learn from one another and to identify ways to improve the health and well-being of all Americans. I would like to extend my sincere thanks to our summit partners, Biogen, Novartis, American Cancer Society, Cancer Action Network, AmerisourceBergen, Amgen, Bristol Myers Squibb, Campaign for Tobacco-Free Kids, Grail, Johnson & Johnson, Novo Nordisk, Planned Parenthood, Walgreens, and all of our special guest speakers, panelists, and moderators. Your support enables APAICS to fulfill its mission of promoting Asian American, Native Hawaiian, and Pacific Islander participation and representation at all levels of the political process, from community service to elected office. I'd like to introduce KPAC Executive Board Member and KPAC Healthcare Task Force Co-Chair, Congresswoman Barbara Lee. Congresswoman Lee has been representing California's 12th district since 1998 and is the highest-ranking African-American woman appointed to Democratic leadership, serving as co-chair of the Policy and Steering Committee and a member of the Budget Committee and the Appropriations Committee. During the drafting of the Patient Protection and Affordable Care Act, Congresswoman Lee served as chair of the Congressional Black Caucus and worked to ensure strong provisions that expand healthcare access, address health disparities, and create incentives for people to live healthy lives. Let's welcome Congresswoman Lee to the APAICS Health Summit.
Hello, I'm Congresswoman Barbara Lee, proudly representing California's beautiful 12th Congressional District, which includes Oakland and Berkeley, California, and the East Bay of Northern California. Thank you to Madeline Milka and the APAICS team for inviting me to participate in the 2023 APAICS Health Summit. I would also like to thank KPAC Chair, a great woman warrior, Congresswoman Judy Chu, and her staff for her leadership. As co-chair of the Health Task Force of the Congressional Asian Pacific American Caucus and a member of the Congressional Black Caucus's Health Task Force, I have fought to ensure that every person in this country has the right to equitable and quality health care. It is my pleasure to work with Senator Mazie Hirono in sponsoring the reintroduction of the Health Equity and Accountability Act, HEA, on behalf of KPAC. We are so grateful to partner with the Association of Asian Pacific Community Health Organizations and the Asian and Pacific Islander American Health Forum that will lead the community working groups on HEA this Congress. HEA brings together not only the Tri-Caucus, but also many stakeholders, such as the Minority Quality Forum, the National Urban League, and UNIDOS. For over 20 years, HEA has served as the platform to bring together stakeholders investing in addressing the underlying challenges that prevent underserved communities from accessing quality health care. We have had tremendous success in implementing provisions from HEA to expand the offices of minority health, improve health data collection standards, enhance culturally and linguistically appropriate services, and more. As we prepare to reintroduce HEA this fall, we need your continued involvement, advocacy, and support. Please commit to joining me and KPAC in our efforts to reintroduce the Health Equity and Accountability Act. Together, we can create a system of care that is reflective of the needs of each of our communities throughout America.
Our next speaker is KPAC Executive Board Member and KPAC Healthcare Task Force Co-Chair, Congressman Ami Bera. Congressman Bera has represented California's 6th Congressional District since 2013. He is currently a member of the House Foreign Affairs Committee, the House Permanent Select Committee on Intelligence, and the Select Subcommittee on the Coronavirus Pandemic. Prior to his term, he served as Chief Medical Officer for Sacramento County and a clinical professor of medicine and Associate Dean for Admissions and Outreach at University of California, Davis. Leveraging his prior medical experience, Congressman Bera has worked extensively on legislation to reduce barriers to accessing healthcare, such as his most recent Easy Enrollment in Healthcare Act, a bicameral bill to simplify healthcare enrollment for Americans by allowing them to enroll in coverage when they filed their federal tax returns. Let's give a warm welcome to Congressman Bera.
Hi, I'm Congressman Ami Bera, and I represent California's 6th congressional district, Sacramento County. I also happen to be one of the co-chairs of APAICS Health Committee, and also am a physician by training. I want to thank APAICS for hosting this healthcare summit and the important topics that are going to be covered today. Going from making sure there's full inclusion of the broad, diverse Asian American, Pacific Islander, Native Hawaiian community in healthcare trials. It's important that you have inclusive trials to make sure that as you're doing research and discovery, you're not excluding particular ethnic communities. In addition, as we've learned from the COVID pandemic, the importance of providing adequate mental health treatment to the broad population is incredibly important, especially in ways that are tailored to specific communities. That's why community health centers are so important and vital cogs in the delivery of healthcare in America, because they do have more of an understanding of the culture of specific communities that they're trying to care for. Lastly, as healthcare technologies advance, we need to make sure that technologies like artificial intelligence, et cetera, are also taking into account ethnic variabilities, and that those technologies are being researched and implemented in inclusive ways. So again, APAICS, thank you for hosting today's summit. Thank you for all the work that you do elevating the voices of the Asian American, Native Hawaiian, and Pacific Islander communities, and have a great day and be well and be safe.
It's my honor to introduce our next speaker, Surgeon General Dr. Vivek Murthy. Dr. Murthy was confirmed by the U.S. Senate in March of 2021 to serve as the 21st Surgeon General of the United States. As the nation's doctor, the Surgeon General's mission is to help lay the foundation for a healthier country, relying on the best scientific information available to provide clear, consistent, and equitable guidance and resources for the public. As the Vice Admiral of the U.S. Public Health Service Commissioned Corps, Dr. Murthy commands a uniformed service of over 6,000 dedicated public health officers, serving the most underserved and vulnerable populations domestically and abroad. During his previous tenure serving as the 19th Surgeon General under President Obama, Dr. Murthy created initiatives to tackle our country's most pressing public health challenges, including the Ebola and Zika viruses, the opioid crisis, and the growing threat of stress and loneliness to Americans' physical and mental well-being. Let's welcome Dr. Murthy to the APAICS Health Summit.
Hi, everyone. I'm Dr. Vivek Murthy, Surgeon General of the United States. It's my honor to welcome you to the Asian Pacific American Institute for Congressional Studies Health Summit. And I want to thank my friend Madeline Milkey for the invitation to be with you once again. This group means so much to me and is doing extraordinary work on behalf of Asian Americans, Native Hawaiians, and Pacific Islanders in Washington and all across the country. It couldn't be happening at a more important moment for our community, a moment where we are too often told that we're not enough, where our contributions aren't sufficiently recognized, and where we too often have to fear for our physical safety at schools, in dance studios, and on the street. I know that much of today's discussion will dig into the ways in which our community is underrepresented and strategies to ensure more inclusion. These are important conversations, to be sure. And we in government are working hard to do our part, especially when it comes to confronting health inequities and the xenophobia and discrimination that have worsened during COVID-19. It's also why President Biden and Vice President Harris have made long overdue investments in Asian American and NHPI communities, expanding access to healthcare and increasing health resources available through the American Rescue Plan. And it's why they've responded forcefully to the unacceptable spike in anti-Asian violence, including by issuing a presidential memorandum directing all federal agencies to take steps to combat anti-Asian bias and xenophobia, especially in response to the pandemic. But before today's conversations begin, I want to take a moment to acknowledge anyone attending this summit or partaking in these conversations who wonders if America is a place where they can truly belong. I know what it's like to wonder about that. Growing up as a kid who didn't look the same as other kids, whose immigrant parents had different language and customs and accents, who faced racism myself and people who told me to go back home. There were many days where I wondered if I belonged here. But the truth is we do belong because we chose America as our home. We worked hard and contributed to our communities. And we are part of making sure America stays true to its ideals of being a home for all those like us who come here seeking a better life. That was a lesson taught to me by my parents in those moments where I wondered if there was a place for me in America. They grew up in a society steeped in class and caste discrimination. They were no strangers to the profound harms that arise when some people are systematically deprived of opportunity, health, and dignity. But through their words and their perseverance, they showed me that we are every much a part of the American experiment in democracy as anyone else. And that's why I, like so many others across government, will never stop working toward that ideal of an inclusive America where everyone can belong, whether they came here a few years ago or a few generations ago. This is about the fundamental promise of America to create a more just, equitable society for all. I couldn't be more proud of the work the AANHPI community has done to strengthen these ideals and to ensure that the youngest members of our community can grow up knowing that their heritage matters, that they matter, and that America is a place that they can call home. Enjoy this summit, and thank you so much for everything you do.
Our next speaker is KPAC Senate Associate Member, Senator Alex Padilla. He was appointed to office in 2021 and is the first Latino to represent California in the United States Senate. He sits on the Senate committees on the Judiciary, Budget, Environment and Public Works, Homeland Security and Governmental Affairs, and Rules and Administration. His top priority upon entering the U.S. Senate has been to address the COVID-19 pandemic and deliver equitable economic relief for working families and communities across California. Prior to this position, he served as California's Secretary of State in 2 terms in California's State Senate. Let's welcome Senator Padilla to the APAICS Health Summit.
Thank you, Madeline, for that introduction. And thank you to APAICS for all that you do to uplift Asian American, Native Hawaiian, and Pacific Islander communities across the country. As we gather together this year, we draw inspiration from the late APAICS founder and trailblazing California native Norman Mineta to fight for equal representation and just treatment in America. And what better way to do that than by discussing something as important and as potentially life-saving as increasing diversity in healthcare and clinical trials. Now, America's strength comes from our diversity, a multiracial, multicultural nation of neighbors supporting one another. But our commitment to equality and finding strength in our differences doesn't stop at the ballot box or in our governing bodies. It extends to all sectors, including the medical field. All Americans, regardless of their background, deserve quality, affordable health care. Yet even in 2023, we often fall short of true health equity in America, including in clinical trials, a vital source for ensuring that treatments are effective and safe for everyone. Our nation's greatest scientific breakthroughs and life-saving discoveries have not always been breakthroughs for every community. And it's the communities who face the greatest health disparities who often face the most obstacles to accessing clinical trials. Barriers can be as basic as language access, especially for AANHPI communities, a demographic that speaks more than 100 languages. All too often, clinical trials group Asian Americans, Native Hawaiians, and Pacific Islanders from a variety of backgrounds together, and not disaggregating treatment data that could be life-altering. Now, if Americans don't know whether a treatment will work for them simply because trials fail to represent the diversity of the population, that's a fundamental issue of racial justice, let alone potentially the difference between life and death. So in the Senate, I fought to prioritize health equity and increase diversity in clinical trials. I was an early supporter of the Diverse Trials Act to promote demographic and geographic diversity in trials. And earlier this year, I was proud to see pieces of our bill incorporated into the annual government funding bill, finally requiring drug and device trials to submit diversity action plans. We took a key step towards greater clinical diversity for the first time in 30 years. That's a big deal. But as you know, we still have far more to do, not just to enforce greater diversity in trials, but to fight to ensure underserved communities across the country can live longer, healthier lives. Thank you again for bringing together experts and officials who can advance the cause of equity and for holding our nation to higher standards of equality.
Thank you for all of your remarks. It is such an honor to hear from such esteemed speakers. Our first panel of the APAICS Health Summit is diversity in clinical trials. One major problem for health equity is ensuring that the studies that test medical treatments reflect the populations of people who will receive them. The COVID-19 pandemic has brought health disparities into the spotlight and further highlighted the stark differences in trial demographics, particularly with Native Hawaiian and Pacific Islander communities. Despite regulatory directives and public expectations, there remain underrepresented populations in clinical trials, such as women, diverse ethnic and racial groups, people living with disabilities, children, and the elderly. This panel will discuss challenges and solutions towards increasing clinical trial diversity. I'd like to introduce the panel moderator, Dr. Leanna Wen, who is an emergency physician, professor of health policy and management at George Washington University, and a non-resident senior fellow at the Brookings Institution. She's also a contributing columnist for the Washington Post, a CNN medical analyst, and author of the critically acclaimed book on patient advocacy, When Doctors Don't Listen: How to Avoid Misdiagnosis and Unnecessary Tests. Previously, she served as Baltimore's health commissioner, where she led the nation's oldest continuously operating health department in the United States to fight the opioid epidemic, treat violence and racism as public health issues, and improve maternal and child health. Let's give a warm welcome to Dr. Wen and our first group of panelists.
Thank you so much, Madeline, for that kind introduction and also for the incredible work that you and your team have done to put together this very important APAICS Health Summit. So I'm very happy that we're having this discussion with the emphasis on health equity. As we all know, health disparities were not created by COVID, but this pandemic has really shone a light on many of the problems that we've known existed, but have been unmasked because of the coronavirus. And we have seen how there are really stark differences in health outcomes based on who you are and where you live. One barrier to health equity is how we're studying health outcomes, and specifically, the studies that test the treatments that are given should reflect the people who are receiving the treatments. And yet, despite regulatory changes and some important efforts by industry and by community partners, there are still a lot of populations that are underrepresented in clinical trials, such as women, diverse ethnic and racial groups, people with disabilities, children, and the elderly. This panel, then, we're going to be discussing the challenges and solutions towards increasing clinical trial diversity, which is essential to our improving health and in reducing disparities. So I am so glad to be joined on this panel by four incredible leaders: Dr. Yang-Hee Wu from City of Hope, Daisha Ralliford from AmerisourceBergen, Linda Murakami from Amgen, and Kim Folks from Novartis. Now, I welcome all of our panelists now and ask that they introduce themselves in a bit more detail in terms of who they are and their organization and the work that their organization is doing. I'm going to start with you, Dr. Wu.
Good morning. Thank you, Dr. Wen. It is a true pleasure to be here and like to thank APAICS for allowing me the opportunity to participate in this transformative summit. I am so happy to know that this is happening so we can improve the healthcare of all of America. My name is Yang-Hee Wu. I am a cancer surgeon working at City of Hope. I am representing today Gastric Cancer Disparities Initiative, which joins Stanford University Care, City of Hope, Harvard University, and many academic and government and private sector leaders. And we are actually addressing the disparities that affect stomach cancer patients, which disproportionately impacts specifically our Asian American, Native Hispanic, Pacific, Native Hawaiian, Pacific Islander communities, including the Hispanic American communities as well.
Thank you so much. We'll turn to Daisha next for your introduction.
Absolutely. Thank you all again for this opportunity to be a part of this very important panel. My name is Daisha Rutherford. I am the VP of Strategic Initiatives in our Diversity, Equity, and Inclusion, COE at AmerisourceBergen. My role is primarily focused on helping the company to address health equity. So I lead our strategic framework for health equity and the activation across the business to make sure it's embedded in all the work that we do as a company. And just so you have a little bit of background on AmerisourceBergen, it's a leading global pharmaceutical solutions organization that's really focused on improving the lives of people and animals across the world. We partner very closely with pharmaceutical manufacturers, with physicians, with pharmacists and other innovators across the entire value chain to make sure that we are facilitating and optimizing access to all of these critical therapies. So we're really excited to participate today.
Thank you so much, Daisha. Linda?
Thank you so much. And thank you to APAICS for the invitation to be a part of this amazing panel. I am Linda Murakami, and I lead for Amgen our health equity, patient engagement, policy advocacy, and advocacy capabilities work that we do. Amgen is a mid-sized California-based biopharma company. We have both a general medicine portfolio and oncology. Pleasure to be here. Thank you.
Thank you, Linda. And last but not least, Kim, for your introduction, please.
Thank you for that. And as was said by all my fellow panelists here, happy to be asked to represent. I'm representing Novartis Pharmaceuticals, and my role at Novartis as global head for increasing diversity in our clinical trials. And my role started early on around the pandemic, as you mentioned, Lena. However, we didn't just start working on diversity there, but corporate-wide, we implemented a strategy, and I can speak more to that as we move forward through the panel.
Thank you. So I wanted to begin today with a level set. And I want to turn to Dr. Wu for this. If you can talk about what are clinical trials? And I alluded to a bit of this before, but why is diversity important? Essentially, why are we discussing this topic of diversity in clinical trials as it relates to promoting and increasing health equity?
Sure. Thank you, Dr. Wen. So clinical trials, as most of us know, are studies conducted in human subjects, like our patients and our population, whether they're healthy or sick, that are required before a novel drug, a combination of drugs, all the things that our pharma partners are bringing to, cure or care for diseases, including cancer. It can include testing of innovative technologies, new treatment methods, or therapeutic strategies. And they're designed so that we can safely and effectively bring these novel treatments to the right patients. So it's really important that there is diversity in clinical trials, so critical to achieving equity in cancer care and cancer care outcomes, because we need to ensure that the benefits of these, particularly for us in the cancer world, of emerging precision oncology directed personalized cancer treatment, which is transforming the lives of cancer patients. We want to make sure that the diversity in clinical trials provides these benefits to our Asian American, Native Hawaiian, Pacific Islander patients, those in our communities. We have learned the hard way that patient experiences and a limited number of studies show that there can be differences amongst the communities of ethnic diversity. There's heterogeneity in the way our patients respond to the drugs, the side effects of the drugs, the efficacy of these drugs. And therefore, we need to know in clinical trial before we give as doctors these drugs or treatments to our patients, the different types of toxicities and how effective the drugs will be in the different populations. And currently, we have very little data about the different effects of drugs on our different ethnic patient populations. So, we really need diversity to increase and improve so that the efficacy and the safety of our treatments can be better.
I really appreciate the way that you lay this out, that this is a matter of better care for our patients. And I think it's also from the patient side too. I can say this as a practicing physician too, that our patients also want to know when we're offering a treatment that we had studied this particular treatment in their population, and not having done so also breeds distrust. So I appreciate this from both sides. Thank you. So I wanted to ask all of you, and since I just went to you, Dr. Wu, I'm going to turn to Daisha next for this, which is I wanted to ask all of you to describe your organization's perspective on diversity in clinical trials. Presumably, all of you are very much in favor of this, but I wanted to ask you more about the work that you're doing, and also how does this impact, in particular, the Asian American, Native Hawaiian, and Pacific Islander communities? So starting with Daisha.
Absolutely. So at AmerisourceBergen, our purpose states that we are united in our responsibility to create healthier futures. And so core to this purpose is making sure that we're contributing to positive health outcomes for all. And as we've already talked about, and according to the Asian and Pacific Islander Health Forum, since 1992, only 0.17% of the NIH budget, so that's the National Institutes of Health, have included NHPI participants. So we know, and Dr. Wu already mentioned, if specific patient pools are not represented in clinical trials, then new medications and treatments may not offer the best possible outcomes for all patients. And so where our company comes in is we provide a platform of pharma and biopharma services to really support pharmaceutical innovation and access. And that includes around the research and development process of clinical trials to make sure that we're advancing access and equity globally and locally for our communities as well as our team members.
Thank you so much. Linda, how about the work that you all are doing?
Yes, thank you. I'm pleased to share. Amgen similarly has the same desire for an equitable health outcome and equitable health for all of our patients and people everywhere. As a global pharmaceutical company, we really think that at the very high level policy system level, it's important to engage. Things like the legislation that was passed and signed at the end of last year around diversity in clinical trials, critically important to us. We also believe that you have to drop that down to the health system level. Initiatives that we partner on and in support look at how you educate and how you resource diverse clinical trial researchers and educators, including your PIs, including the navigators. It's important for patients to see and to know that they are reflected in those who are doing the research, talking to them about trials, explaining it to them. This allows for a different level of connection. And Dr. Wen, to your point, trust that can be built when you're hearing it from somebody who looks like you and has perhaps the same background, kind of the same cultural, maybe language as well. For us, it's even more important to really drop it down into the program level. So when we are investigating different assets to treat things like gastric cancer, which overrepresents in the AAPI-NH community, we really think it's important to include the patient perspective. When we have patient insight activity, we ourselves require that 50% of the patients that we work with to provide insight as we design trials and protocols and look at what important outcomes are for different assets, that they come from a diverse population that is overrepresented in the disease area. So for us, we really want to take a very kind of front to back end approach to how we engage, thinking very carefully about each of the patient populations that are impacted.
Thank you for that, Linda. And Kim, can you also discuss some of the work that you are and the perspective that you're doing that you represent at Novartis?
Yeah, so some similar activities, of course, education is very important, but I'll speak maybe some specifics. So it was important when COVID hit that we went from working trial by trial in our organization and depending on the teams to recruit, but instead incorporated a corporate strategy. And why that was important is this allowed us to embark on an initiative where we are supporting more diverse healthcare providers, even starting at STEM research in grade school and high school and college and beyond, so that there is more representation in the healthcare system. We know that in some diseases, there is less than 5% diverse physicians. In some diseases, there are 0 diverse physicians in the United States. So this is a big impact. But also what we did with a corporate strategy, we've been able to incorporate the US disease prevalence into our development plans, so that one of the issues is that the teams weren't aware of the disease prevalence for that indication within the United States. So for example, we found MS impacts 25% Black African Americans as just one example. Well, teams don't know that, then they're not going to put strategies in place and tactics to reach out to those patients. So that was a big part of what we've done to embed this across the entire R&D continuum at Novartis.
Thank you, Kim. And I want to come back to you, Dr. Wu, if you can talk about the work that you're doing at City of Hope in this regard.
Sure. So we at City of Hope have partnered with Stanford and Harvard and the other academic groups such as UCSD and USC, and as part of the gastric cancer disparities initiative. So I'm so happy that Linda brought up the disparities and the adverse impact that gastric cancer is having amongst Asian American communities. So we have created 2 summits that actually specifically address the need for early detection and prevention of deaths due to gastric cancer. So these educational summits and collaborative summits have brought together, and the initiative have brought together these minds that will focus on ways of early detection and prevention of gastric cancer through, first, we want to acknowledge that there is inequity and lack of diversity in the clinical trials that would identify methods for early detection and prevention. It's very important that we are able to design studies that will be able to identify ways for early detection and prevention. We don't even have that, the way breast cancer has done, where lung cancer has done. There are no trials to identify within the United States what the best way, what the most cost-effective way, what is the most life-saving way of early detection. So the Gastric Cancer Disparities Initiative has actually nominated a early detection, primary prevention of gastric cancer nomination to the USPSTF, asking them to review the possibility of national screening for H. pylori, which is a very simple test that they can do to detect H. pylori and treat, which can prevent or decrease the risk of gastric cancer amongst the high incidence Asian American communities. And thanks to the USPSTF, they have actually selected it for review. However, the secondary prevention request for upper endoscopy in our high-risk population has not been selected. And so the groups at City of Hope in Orange County, funded by CURE, will have a clinical trial that will open up very soon in June, addressing the high-risk populations, Asian American, Hispanic Americans, for secondary screening of at-risk populations moving forward to identify risk factors that we need to know to screen our patients for gastric cancer.
I really like the very specific examples you've given, because I think that a lot of times we're talking about the problems. And it's nice to see that there are very specific actions that can be taken and that they have a response, right? As you mentioned, the United States Preventive Services Task Force is now reviewing your proposal, which is great because there are implications for clinical practice, and then there are implications also for insurance coverage too, if some types of measures are covered versus some are not.
Absolutely. And I think it's very important that there are very specific trial designs that include the NHPI communities into the clinical trials so that they're interpretable that way. If you don't design the clinical trials properly, the data is not useful or not applicable to our communities.
Thank you for highlighting that. So I want to turn to another question, because we're now getting into the issues of challenges. And I wanted to ask you all, starting with Kim, we'll go backwards in the order that we were introduced this time. But I want to ask you, Kim, what are the major challenges that are preventing faster, more efficient development of greater diversity in clinical trials? And as a correlate to that, I also want to know, in what ways is your organization working to address these challenges?
Yeah, thanks for that. And not to oversimplify at all, but I'll say the three maybe top barriers from my view is trust in the healthcare system in the United States, and trust in pharmaceutical companies as well is lacking. Also, the importance of access to clinical trials. We know clinical trials are run in less than 2% of the zip codes in the United States most of the time. So the access to clinical trials can be very narrow. And then the education or awareness about clinical trials is also a barrier. And in terms of trying to solve those barriers, we work with partners to help us, people who are already trusted in their community, who already work with those communities. And that differs depending on the populations that we're working with, but it could be churches, it could be YMCAs, it could be sorority fraternities, wherever these communities receive their information from trusted sources. We work with those people to help educate about their disease, about the importance of screenings, about the importance of managing their disease. And then also later, because we don't want to be seen as doing helicopter research, that we talk about the potential of clinical trials being an option.
I like that. I also think in terms of threes, and so can definitely think about the three issues of trust, access, and education. Thank you, Kim. Linda, how about you and your perspective from Amgen?
Definitely. In addition to agreeing with everything Kim laid out, which was fantastic, I would add to it, oftentimes it's not only availability of clinical trial. When you have a really great situation where you have the right patient who would qualify and who is agreeable and interested, oftentimes programs are not set in place that actually allow them to participate. And that can be transportation. It can be, the missed work and what that means for their income and their ability to support their family. There can often be language barriers. If they are in a trial, we want them to stay in the trial. And so understanding how to manage some of what might be the side effects to that. So when we think about it, in addition to the very important thing about building trust, making sure that we are locating trials, not just in centers of excellence, which is very important, but in the community, because we know most patients are seen in a community setting. So for us, kind of the solve is to work with organizations like the Community Oncology Association, COA, and others, bringing in the patient groups who can help us identify what programs are necessary, the many languages for our community, the AAPINH community, that we need to have materials in. And so for us, it's kind of the marriage of, kind of the big systemic issues. But really for us, it's how can we get to the trust issue from a variety of ways so that we can all be successful.
It's interesting, Linda, as you're talking about the various barriers that are in place, it makes me think a lot about what we talk about in public health all the time about social determinants of health, right? That it's not just about the care that you receive, which is important, but also the transportation, the food, the housing security, all these other things that factor in and that are, as I hear all of you talking, part of access to clinical trials too. Daisha, let me turn to you next.
I mean, that was perfectly stated, Dr. Wen. I'm going to actually share some nuances in terms of how we are helping overcome some of those social determinants of health issues that come into play when there are access challenges. Linda already mentioned, that many patients don't necessarily have access to clinical trials because they live further away from clinical sites. And also just talking about social determinants of health, there's been studies and information that show patients with household incomes below $50,000 were 27% less likely to participate in clinical trials. And as that income drops even further, so did the likelihood of trial participation. So whether you're talking distance, time, and lack of resources, those are absolutely agreeing with my panelists, some of the factors that make it difficult for groups of patients of diverse backgrounds at times to really participate in clinical trials. And so one of the things that our company does is focused on decentralized and virtual trials, which really allow patients to participate in clinical research from their homes. And that really is starting to emerge as a means of overcoming some of these challenges and barriers that we've talked about. So through World Courier, which is our global logistics business, what we do is we enable patients to participate in clinical research by shipping those clinical supplies, those investigational medicinal products and devices on behalf of a pharma manufacturer to that patient's home. And decentralized trials are activated what we call through direct-to-patient services, really allowing those patients to participate regardless of their income, regardless of their location, regardless of any underlying health concerns or even a physical disability. And what we found among the benefits, moving that trial site location and some of those activities into a patient's home has been shown to, number one, increase recruitment by over 60% in some of our trials, as well as improving patient retention by over 95%. So once again, I think we're all talking about how do we bring the trials closer to the patients, and whether it's in the community setting or in our case, into a patient's home, that's some of the ways that we want to overcome some of those challenges and barriers faced by patients.
That's terrific. And I know, Dr. Wu, you had mentioned some of this before, but I wonder if you can give some other examples perhaps of challenges as well as what your organization is doing.
So I think that there are structural and systematic challenges, and I think all of you have described what they are in some more detail. But there are, when I look at it in terms of the way the data is being collected. And so in terms of the design of the study itself and the way the data is collected, one of the barriers, I think, is lumping all Asian Americans together without disaggregating the data. And I think this is really important when we are designing the study to understand which subpopulation of Asian Americans would benefit a trial the most or not. And I think that goes to the beginning of the trial design. And then in terms of, as a surgeon investigator who implements clinical trials, enrolls patients on these, I know that one of the biggest barriers is just lack of awareness of these clinical trials among our communities and our patients. Their access to information about the clinical trials are already very difficult because the barrier itself is language and the way we communicate health information to our communities in the ANHPI communities. For example, the Korean American first generation listens to the Korean radio in the language, right? So if you have a website in English on, let's say at the NIH, who is going to find that, right? So like Daisha said, we want to go into the community and we need to share that, like break the barriers of that wall, that the language barrier, the cultural barrier, the lack of education. And so but when you do, and when the trust is, you can earn the trust, 30% of my patients are Asian American, 30% of my patients are Hispanic American, and the rest non-Hispanic white mixture. They enroll in our clinical trials represented in that number, so we have had success in our, surgical outcomes trials, prospective clinical trials, where more than 35% are Asian American and Hispanic American. So the barriers can be broken, but the awareness and a reach out needs to be there. And I think that resources, the barrier, so everything comes down to funding and resources and priorities. So, I'm so grateful that, the represented here is already investing a lot of funds to reach out to our communities and diversify our clinical trials, because without the support of pharmaceutical industry, push by government, we as physicians and clinical trialists can get the patients to the trial, but we don't have the resources. It takes twice as much time to consent an Asian American who speaks Fukienese than someone who speaks English, right, to a trial. But I need that time because I want to enroll patients that will benefit and represented with diversity in the clinical trial, and Asian Americans, and they may not speak English. So our consents have to be in different languages. We need translators, navigators, all of these things. And bottom line is, it comes down to resources focused on making sure that this diversity exists in clinical trials.
Dr. Wu, what you just said is a perfect segue for the next topic that I want to have us discuss, and I'll have you lead off since you were already getting there when it comes to resources, right? I mean, to the issue of what more do we need. And my next question is, in a sense, a call to action for how can government and private sector come together to better support this important work in clinical trial diversity? Because I think all of you have said, here are the challenges, here's what can be done. Dr. Wu, you laid out the need for resources, but what more do you think? How can policymakers and the private sector also? How can they help?
Well, as selfish as I am for my gastric cancer patients, stomach cancer being the least funded of all the solid tumors of disparity, with one of the greatest disparities in outcome and incidence. I would want to call Congress and NIH and pharmaceutical industry to recognize that this is a problem. With that being said, more funding to identify first cancers of disparities with that adversely impact the Asian American community is absolutely a must. This includes stomach cancer, funding to increase funding to improve outcomes. And also, I think what we need from pharma is funds directed to improving access specifically for Asian Americans to increase enrollment in the trials, like in the areas that you're doing already, but even more, encouraging clinical trial centers to reach out and enroll more Asian American patients, of course, that are appropriate. And so the funding needs to come from the hospital, itself prioritizing that this is an important issue within their clinical trial research team, pharma to help fund such a thing, and the government to increase funding in areas of cancer disparities that adversely impact the Asian American NHPI communities. So it's not one person and me going out to make sure as a clinical trialist or a cancer surgeon that my patients are aware and that the communities that are underrepresented are not underrepresented anymore, because extra effort needs to be placed there. So I think this kind of forum and summit, Dr. Wen, that you put together with the APAICS is truly one of the first steps in getting this done.
Here for APAICS and bringing us together. And we do have a number of companies represented. And so I not to necessarily ask you all for a response in this regard, but I would love to know from all of you as well, starting with Daisha, what you think the government and private sector can do more in terms of coming together to better support clinical trial diversity.
Sure, no, happy to talk about the importance of data. I know Dr. Wu mentioned it earlier, but I think there's an opportunity, especially when I think about our company, about the importance of sharing data best practices and next practices. And data, as we all know, brings transparency to really understand where we are today and where we want to go. And as mentioned earlier, there's heterogeneity in the Asian population, and it's so important that we really get clear on where those opportunities are to address disparities and make sure that we are therefore can develop, especially in our case, some of the tactics and practices that will help us partner very closely with all across the pharmaceutical supply chain to really solve those disparities. So that's one area. Another area of government, really quick, also connected to data, and this is some work that we've started that I would love to continue, is we've been working with the Office of Minority Health as we continue to build models of data within our company to really support pharmacists, to support community oncologists, to understand who's in their community and where there are opportunities to serve those who are underserved. And that includes, as it relates to clinical trials, we're building partnerships to share some of those public data sets and getting technical support and lifting up those best practices that are occurring so that we all can continue to learn more and close those disparity gaps where they exist.
Thank you so much. Linda?
Definitely. I absolutely agree with Dr. Wu and Daisha. I think one of the approaches at Amgen that we're taking is to really pool resources. So to Dr. Wu's point, we do need to all work together. And what we realize is that not one company, not the government, nobody has enough money to do it all. And so our approach has been to join with a number of our sister companies to focus on things where we can have an impact. Some of the things that immediately come to mind certainly are the training of the clinical trial investigators, navigators, and whatnot, to make sure that they are educated, to Daisha's point, going down to the STEM level and making sure that you are diversifying from early education all the way up through your advanced educators, the importance of having access for those diverse populations. For us, a big focus is also making things language appropriate. And when we think of language, we do think of health literacy, as well as thinking about the many languages that this community represents. So for us, it's as we're thinking about starting a clinical trial, if it ends up as it will in clinicaltrial.gov, I hate to admit it, I have gone in there, tried to look at the trials. I think I'm fairly educated. I've worked in this area for a long time. And to be honest, I find it somewhat confusing. Some are written better than others. And so as a company, often what we consider is putting together at the early side specific trial websites that can be language appropriate. We work with an advocacy partner to make them understandable, and then of course have the appropriate link back to clinicaltrials.gov. But for us, that is an area where we think there's opportunity for collaboration, certainly with governments, certainly with other manufacturers. It wouldn't be smart to reinvent the wheel and have a zillion different locations. For patients, that can be overwhelming. in addition to already thinking about and knowing about clinical trials. So for us, we feel like there are a lot of places where we can pull resources, we can share best practices. Certainly, I feel like we and our sister organizations are looking for the same patients in a lot of cases, and that also can be very challenging. So for us, it's really collaboration in thinking about how we can all collectively solve this problem.
Wonderful. How about you, Kim?
Thank you. I may go back to an ask of government, and I don't know if it's the state level or federal level, but as we've been trying to expand from academic center research and particularly in the oncology space into the communities, what the physicians there are telling us is, I mean, they want to do clinical research. They don't have time to do clinical research. So grants or funding to allow more community physicians that then can take on the clinical trials is at least to get them started, because that's what we're seeing as the challenge now is we have the studies, we know where the patients are, but we don't have the physicians and the communities that are able to take on these clinical trials.
Well, I want to end on a hopeful note, in which is I want to ask all of you, and starting with you, Kim, what are the opportunities and future possibilities that our communities should be excited about?
Well, we've touched on a lot of it here today. I mean, the future is absolutely digital clinical trials in one way, shape, or form. We've got a lot of work to do in that space because our clinical trials range from some are more simple, and I don't want to make a statement of what's simple. Some people might disagree, but there are more simple trials and there are much more complex trials and much more rare disease trials. And so that may take us a while to be able to really push the digital space, but that is the future. Also, I see the future being with apps on phones, with healthcare systems, that one day that they're going to be able to, based on my diagnosis, put in my app all the clinical trials that I actually could qualify for. And actually that goes to my physician too. So it at least starts a conversation about clinical trials, more awareness, and then of course locating the doctor for the clinical trial afterwards. So those are a couple of things that I see in the future.
Thank you. Daisha, what do you think? What are the opportunities and future possibilities that our communities should be excited about?
Sure. No, appreciate that. So one of the opportunities that we're excited about, and we've talked a lot about today, is the importance of moving things to the community. And so moving increased awareness of clinical trials and the recruitment through more community-based recruitment of patients in clinical trials. I know Dr. Wu talked earlier, of course, her patients trust her. And so one of the things that we're looking at is how do we partner closely with specialty physicians, community oncologists, to provide tools to them, one that we've developed around Clinical Trial Navigator, to make sure that we're able to match the companies with independently owned community oncology and specialty practices, and make sure that the physicians who are treating those patients and building trust with them can help to increase recruitment opportunities and expand the pool of potential enrollees in different trials. So we look forward to partnering with physicians because we know the role that they play and ultimately the trust that a lot of them have built with their patients, especially those from diverse backgrounds.
Thank you. Linda, can we see if we could hear you?
Can you hear me?
Yes.
Yes, we can.
Okay, thank you for the question. From the Amgen perspective, one of the things that we believe is an area of excitement, doing research that we're doing in disease areas that overrepresent in the AANHPI community. As Dr. Wu mentioned, gastric cancer, stomach cancers are often underfunded through the NIH and others, and it is a focus area for our company. And when we're looking at what research needs to go into it, for us, it really is looking very specifically at the community itself, wanting to make sure that we have partnerships with the appropriate other researchers so that we can share appropriate information. To Kim's point, instead of starting, kind of at a base, the more data we can share, certainly the more advanced everybody's research can be in delivering treatments to the community. So for us, it really is looking at, important disease areas like the broad stomach cancer, gastric cancer area, and we're very hopeful
Thank you so much. Dr. Wu.
I predict, or I hope that in my lifetime, in my career lifetime, or my lifetime, that we would achieve equity in healthcare in the United States. And that when you're Dr. Wen, when you're talking about what is expected in the future, I expect nothing less than that we eliminate disparities in cancer care in the United States. It's not acceptable. And we all know that, but I think now the dialogue has started and it must conclude with success. And so I think we need to move with urgency. It's a positive sense of urgency with the momentum that has been created here with APAICS summits and support of KPAC and all the organizations in academia, like the Gastric Cancer Disparities Initiative, the social determinants of health work groups that are in individual academic centers and communities, such as City of Hope, and all our communities, networks, especially as researchers collaborate and government listen. I'm hoping by 2050 that this would not be an issue anymore and all of us will be celebrating equity. But I think combining all the things that we have discussed here, it is not one action, but action of the collective that's going to get us there. And I hope that's the future that we're looking at, that there will be no disparities in cancer as it adversely affects the Asian American, Native Hispanic, Native Hawaiian, and Pacific Islander and other minority communities.
What a terrific call to action and note for all of us, and very optimistic note for all of us to end on. I think we really covered a lot in this panel today about why it's important to level set, right? Why it's important for us to have diversity in clinical trials, that it's better for medical care, for trust. We've talked about the structural challenges, historical challenges, challenges in data collection, but also the things that can be done when it comes to getting trials closer to people and having overcoming various barriers like language and even who's doing the studies with much more attention. And I've just been so hopeful listening to the practical solutions, many of which have already been implemented by your organizations, but many more that require the collaboration of public and private partners to come. So I hope that you all will join me in thanking Dr. Yang-Hee Wu, Dr. Yang-Hee Wu from City of Hope, Daisha Relaford from Amerisource Bergen, Linda Murakami from Amgen, Kim Folks from Novartis, and of course, thank you to APAICS for hosting this session and for coordinating this wonderful health summit. Thank you.
Thank you.
Thank you.
Thank you.